All right, so we have a 67-year-old man with a history of hypertension and diabetes mellitus who presents to the emergency department with sudden onset of left leg weakness. His exam is notable for 3 out of 5 strength in his left lower extremity, as well as diminished sensation over his left toes, foot, and leg. He has a flat affect and appears slow in his speech. Which of the following vascular territories is most likely affected in this patient? All right, so this is a pretty straightforward question. You're going to need some knowledge of territory of infarct in strokes. And the answer choices here include A, left lenticulostriate arteries, B, left posterior cerebral artery, C, right anterior cerebral artery, and D, right middle cerebral artery. Some key pieces of information here is this patient clearly is set up for a stroke. He has hypertension, diabetes, and he has sudden onset of left leg weakness. So we're told right away that the patient's motor symptoms are on the left side. He also has diminished strength here. We see that 3 out of 5 strength of the left lower extremity. We're also told a few more important pieces of information. He has diminished sensation on the left side as well. So now we know he has left-sided motor weakness, left-sided sensory. And he also has a flat affect and slow in speech. Okay. Now we need to determine which vascular territory this patient is suffering a stroke in. Anytime on an exam and even in clinical practice, anytime I see that someone has maybe a personality change in a setting of ischemia, I always think frontal lobe. We have the prefrontal cortex there, and a lot of times that's involved. So right off the bat in this question, I'm thinking something in the frontal lobe. Now, in ischemic stroke, we know that the most common artery involved is the middle cerebral artery, and we see that as one of our answer choices. And typically, the anterior cerebral artery is less involved in clinical practice because of collateral blood flow from communicating arteries, the anterior communicating artery. But in this case, on an exam, right, things aren't always perfect. And what we really need to do in this exam is identify the key features given in this vignette and which most closely resemble the vascular territory here. And what we see here may differ than in clinical practice. So let's start with answer choice A, the left lenticulostriate arteries. Now, these are small arteries off of the middle cerebral artery, and they're small. They cause like these lacunar infarcts that you may have just motor and some sensory deficits. They go into the deep structures of the brain. But in this case, we would be seeing right-sided symptoms. And in our vignette, we're given the left side. So we could, in fact, cross out answer choice A for that reason. So let's do that. Now we go to answer choice B, left posterior cerebral artery. For exam purposes, anytime we're talking about the left posterior cerebral artery, this supplies the occipital lobe. I always think that the patient will have visual symptoms, right? They may have visual field cuts. I always think about ataxia, vertigo, and they'll have contralateral motor weakness as well. And therefore, given that, we see that this patient, this would be ipsilateral motor weakness because the answer is left posterior cerebral infarct. So I'm going to cross out answer choice B as well. Now we're on answer choice C, right anterior cerebral artery. So this is this one's seeing pretty consistent here. and we're left with C and D, right middle cerebral artery, also associated with motor and sensory loss. So, this is definitely a possibility as well. So, how we distinguish between these two, specifically, let's say on an exam, is in anytime we're dealing with the right middle cerebral artery on an exam, we will have contralateral findings of motor weakness, sensory loss, but almost always you'll be given some type of deficit in the face as well. Patients may have a facial droop, they may have slurred speech, and the other part of this is that with the MCA infarcts on an exam, you will usually have upper extremity weakness greater than or more involved than the lower extremity weakness. Now, what do we see in this vignette? We see the patient has left leg weakness. We are not given any exam of the upper extremities, nothing about the arm. So we have to presume when we're not given that there's an abnormality, that there is no abnormality. And so the ACA, or the anterior cerebral artery, is known to cause greater motor and sensory deficits in the lower extremities than compared to the upper extremities. So these will be common answer choices on exams. You may have to distinguish between the ACA, anterior cerebral artery, and the MCA, middle cerebral artery. And, clinically, this is a different story. But on an exam, the way you do it is you most likely will be given these lower symptoms greater than upper, and that means the ACA. And we're also have the benefit of the patient in this vignette having a flat affect and slow in his speech. So the flat affect is what gives it away for me that I could really confirm on this question that this is going to be the anterior cerebral artery because of those types of personality type of deficit. So let's go. We're going to cross out answer choice D here. And I am going to go with the right anterior cerebral artery, answer choice C. And sure enough, that is correct. And we can see here the distribution of the anterior cerebral artery. Hey everyone, before you go, if you're interested in your own QBank, whether you are an MD or DO, a PA, or an MP, simply go to roshreview.com and sign up for a free trial. See if Rosh Review's content is right for you. Keep learning, keep working hard, and always have a sense of mission about your work. Now is your time. This is Dr. Adam Rosh, signing off.